Thank you for joining us, sir. Thank you so much. So, without much ado, I will hand it over to Dr. Sudhi to start the further proceedings. Over to you, Dr. Sudhi.
So, so I invite Dr. Tushar Chokshi. He has been my senior and like a Sankat Mochan to me. Whenever I have a problem in Roorkee, I contact him. So, as Dr. Divya has already introduced, he's started for the first time. He has started infographics, AI, and Chat GPT in anesthesia. And he, matlab, way long back, he started taking interest in TIVA and TCI, and we were always discussing all this about him. So we in Roorkee town, we usually give TIVA. We are giving TIVA all the time, but we are using some manual techniques, infusion techniques and intermittent boluses. But with newer knowledge, with good knowledge, we will definitely shift to now mechanics, this thing, TCI-TIVA. So I invite Dr. Tushar to start
Uh,
to share his talk.
yeah. Happy World Health Day, and thank you, Sudhi. And I'm very thankful to Uttarakhand ISL, and I'm thankful to Dr. Divya, Dr. Sudhi, and welcome to this webinar. And very grateful to my dearest, lovable, and most respected friend, Dr. Bala Venkat and Dr. Virendra Sharma. I'm Dr. Tushar Chokshi. My dream was for starting TIVA in all over India since last 30 years. So now it has fulfilled since last 5 years, and we have formed the society. Can you see my slides?
Yes, sir, it's visible.
Okay. So my topic is A to Z of the TIVA, and TCI means target control infusion and TIVA means total intravenous anesthesia. I will talk about from basic to advanced and future part of the TCI in TIVA and TIVA. And my fellow colleague, Dr. Kalpana Shah, will take over the TCI, target control infusion, in half an hour. Both are given half an hour, so we'll complete in the time. So my audience question is, how many of you are giving TIVA and TCI? What is your definition of TIVA and TCI? And what is your experience of TIVA? Will you give TIVA and TCI in your practice? See, these questions are I'm asking to all webinars and all my workshops and all my lectures, physically or virtually, because nowadays, since last 5 years, I am seeing that most of the people now have started the TIVA and TCI practice all over India. But TIVA, you had given total intravenous anesthesia since your residency days. So my lecture highlights will be history, definition, types of TIVA, indication, advantage, disadvantage, TIVA drugs and TIVA combination, methods of TIVA, TIVA in different groups of patients, TIVA and TCI checklist monitor, surgical procedure done under TIVA, TIVA updates, TIVA apps we are using, future of TIVA, and what take-home message you will get from my lecture, and what is your opinion about this after your webinar, my lecture. So if you see the history of the TIVA, not TCI, but TIVA goes just 350 years before, in 1656 from the Oxford. And in 1936, the change here came with the invention of the pentothal sodium. And then all the intravenous drugs was introduced, from ketamine to propofol to remifentanil, from dexmedetomidine, and newer agent was introduced in world since last 2 years is remimizulam and ciprofol. So TIVA is 350 years before, and just inhalation started. Just we have seen that our anesthesia day is just 1846 this October. So it is 175 years before. So TIVA is older than the inhalation agent. So these are the timeline of history of this IV anesthesia. Now, what is the definition of TIVA? Just concentrate over these slides. What is the definition of total intravenous anesthesia? It is a technique of general anesthesia which uses combination of the drugs given exclusively by the intravenous route without the use of inhalation agents. No inhalation agents or gas anesthesia are given, including nitrous oxide. These are the misnomer. Here, people are thinking that nitrous oxide comes in the TIVA, but mind well, nitrous oxides are not given. But oxygen, compressed air, or heliums are the exception. And TIVA is, second myth is, TIVA is used in induction. That's all. No, TIVA is used in induction as well as maintenance. So these two things you should be clear in your mind when you are practicing at TIVA or TCI. Now TIVA is becoming popular since last 5 years because of the corona. Why? Because at that time we have seen that gas gives rise to side effect. Now, what are the types of TIVA? This is a very good slides I have prepared first time in India and first time in the world. what are the types of the TIVA? With endotracheal tube, without endotracheal tube, with supraglottic airway, without supraglottic airway, with nasal airway, with oral airway, or without this any nasal or oral gazettes. So this is not like that. TIVA is only when we are not using any gazettes, but TIVA can be given with these are the gazettes also. What are the simple TIVA indications? See, any surgery from head to toe, any patient from neonatal to geriatric, any indication from any system to part of the body, any operation, you give the name of the operations and we can be done. It can be done under the TIVA procedure. So transfer of main indications, transfer of the anesthetized patient between environment, almost in all surgical, airway procedure, PONV risk, then daycare surgery, short procedure, trainee teaching, non-operative room, NORA situation, anticipated intubation and extubation difficulty, and malignant hyperthermia patients because of the inhalation problem, remote location. In neurosurgery and neuromonitoring, TIVA is used far ahead than any specialty, and even patient choice. TIVA advantage, except for a slight prick in the arm, the patient is unaware. When we start TIVA, we have to take the IV line. Then no mask over the face. Patient does not feel any smell of the inhalation agent. No sudden concentration or gas or vapor. No risk of malignant hyperthermia. Less chance of emergence phenomena. And there shouldn't be no smell of the volatile agent at all in the room. And patient is usually most grateful. So you see that there is a less PONV, less operating room pollution, and in any situation in like war situation, ambulance transfer or unexpected condition, we can use the TIVA. So TIVA can be given favorable to almost all body system. You name the system, it can be favorable. So these are the listed systems. Now there are coin has two sides. So there are some minor advanced disadvantages. Pain on injections, like when we prick with the vein flone or any needle, there is slight pain. So this is the first precursor to start the TIVA. Injection is irreversible. Disposable may be costly, but as Bala Venkat said, the pumps are now, it is very economical price. When we started 5 years back, the pump was available at 2.5 to 3 lakhs rupees TCI pump. Now it has come down to, because of the 5 companies, 6 companies are producing in India. So these are 1.5 to 1.8 lakhs. Incidence of awareness is not, if not given properly. So I recommend all people, those who have started TCI or TIVA, they must use anesthesia depth monitor. Undetected error in delivery device. If you are not learning well, if you are not attending any workshop or not learning for TCI properly, then there is a chances of awareness during your TIVA. Not having another apparatus to carry on the TIVA, possibility of not finding the vein. If you don't find any vein, then you cannot start the TIVA practice. Portions in prolonged procedures, difficulty in knowing blood concentration. So what happens? TIVA completes the anesthesia circle: hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, neuromuscular blockade. All the TIVA drugs can give this type of the actions, mixed or individually. So what else you required in giving TIVA? Which are the TIVA drugs? Now TIVA drugs with their advantage, majority of the drugs which you are using in your practice, they are easily available in almost all the operation theater and outside OT. And all these drugs can be given to any subset of the population from pediatric to geriatric in easily titrable dose. Now you see, when we started our inhalation agent, then last inhalation agent sevoflurane was introduced in 1979. Then after, since last 40 years, 40, 50 years, there is no inhalation agent was introduced. At least I don't know. But every 1 year, every year, new anesthesia drugs are coming. Even ciprofol is invented in 2024 in China. Before that, ramimezolam was invented in 2023. So these are the continuous process where all the drugs, even some 2-3 drugs are also in pipeline to introduce in 2026. Now, this is very important slide. Which are the drugs was still when the invention of the anesthesia done till now, what are the drugs were invented? There are 71 drugs that are invented, and in use there are 50 drugs. Out of these 50 drugs, we are having a liberty of using 30 drugs in the TIVA practice. So what else you require? Start your TIVA practice with all these drugs. You have most liberty with this using with TIVA. Now ideal TIVA drug: rapid onset of action, rapid and predictable recovery, potent and lipid soluble, also water soluble, stable in any solution, whether you take any pints or any sort of any injection, It can be mixed with the either IV anesthetic agent without any problem. No prevascular sloughing, not absorbed by plastics, does not promote bacterial growth, and devoid of adverse side effects and low cost. Now, if you tell that me that okay, which drugs is coming most ideal drugs, so I tell that okay, propofol, etomidate, and this our new agent dexmedetomidine is coming nearly to this ideal TIVA drug. All these TIVA drugs toolbox are available in the OT, from dexamethasone to propofol, ketamine, induction agent, all muscle relaxation, beta blocker. You name the drugs which are available in our OT, even outside OT. So which are the anesthetic drugs? Before starting my all IV anesthetic drug, I will go through the one by one with my infographics. You know all the drugs, but I will give some glimpses about some of the drugs which we are using. These are the propofol. Propofol is a main prince. We called it as a prince of the TIVA and TCI. It's a prime drug. Initial dose is 2 to 2.5. But when TIVA mixture when it is used, then it is 1 to 1.5 milligram per kilogram. Infusion, we are giving 6 milligram per kilogram per hour without TCI pump. And for TCI, Dr. Kalpana will take away all the details about this, how to use it. Co-administration of the TIVA propofol and remifentanil is the main drug combinations in TCI. Now, these are the right side. I have listed the TIVA dose and TCI dose of the propofol in some of the milligram per kilogram per hour. So this is the propofol. Propofol was invented. It was like a switch on anesthesia, and it has changed the anesthesia practice all over the world. You just give me the name of any anesthetic which have not used this propofol. Almost all anesthetics are using propofol, and propofol is like a bread and butter to all the anesthesiologists. Now, second drugs, my most popular drug is ketamine. It is across the globe since last 50 years. And one of the survey done in the across the globe that which is the most popular, I'm not telling most used drug, but is the most popular drug is ketamine. Key role in main drug in anesthesia, it is NMDA antagonist. I call it as a brahmastra for the anesthesiologist in TIVA. Whether you practice TIVA or inhalation anesthesia practice, but your patient is light state or patient is aware or whatever, you just give small dose of the ketamine and patient is not aware of anything. Ketamine in TIVA is used very judiciously. It can be mixed with all type of anesthetic and narcotic agents in single syringe. Ketamine can be mixed with the midazolam, propofol. Then in etomidate, it can be mixed with the dexmedetomidine. I will come after that. And one of the established mixture of the drug in the TIVA mixture. So this is the ketamine. WHO has listed as an essential medicine. Nowadays, it is a Schedule X drugs in our anesthesia practice. Third drug is dexmedetomidine and alpha-2 agonist. Out of this, all propofol, ketamine, and dexmedetomidine, I use that dexmedetomidine is most ideal anesthetic agent. It is a physiological, it gives the physiological sleep. So I will recommend all the anesthetics, those who are not using dexmedetomidine, use dexmedetomidine. It's a very good agent and the most ideal anesthetic agent with all the properties of anesthesia. You just give hypnosis to analgesia to anesthesia. And in pediatric practice, after combination of this dexket, means dexmedetomidine and ketamine, it has changed the pediatric practice in TIVA and opioid-free anesthesia, even in NORA situation. Patient is sedated but arousable. So dose range is 0.5 to 1 milligram and maintenance infusion is 0.6 milligram per kilogram per hour. This is dexmedetomidine infographics. Now, those who are not using dexmedetomidine prayer, I have in the voice of dexmedetomidine, I created one prayer. Hey buddies, I am dexmedetomidine. My pet name is Dex. I'm complete your friend to play with you in games. IV, oral, SA, spinal or nasal, but my favorite game is intravenous with all stages, sedation, hypnosis, analgesia, anesthesia. I love to play with the small babies to old age players, but during playing with me, be careful. I'm very delicate and fall down with the weak players. I can also play in the indoor stadium, ICU patient, continuously for 48 hours. I'm always available. So let us play and enjoy with me. Don't neglect me through I am new player. Etomidate now available in the clear state as well as in the milky state. This is an excellent cardiostable drug. It is a reserved drug for the cardiostable non-cardiac surgery for the cardiac patients. So I have very few opportunity to use these drugs, but it is very good agent for the intravenous agent and TIVA practice. So this is intermediate infographics. Now opioids. There are two opioids we are using, fentanyl and remifentanil, exclusively in there. Nowadays, fentanyl is outdated drug. So remifentanil came in the market since last 1 year in the India. So it is available in India as a 1 milligram and 2 milligram vial. In India, initial dose and everything will be told by the Kalpana. But in TIVA practice, it can be given by infusion. Never give IV direct shots by anybody with this. I am getting every third day by the Indian anesthesiologist that we had given remifentanil IV straight away and patient went into arrest. So please, please, please don't give remifentanil IV straight. It has to be given by the infusion pump or TCI pump or by the some of the diluted manner. This message should be kept in your mind. So this is fentanyl. I purposefully kept in black and white because now it is a very outdated drug, fentanyl. Though people are using, but I am not using. I am using opioid-free anesthesia. See, this is remifentanil infographics. Now, new drugs came in the market in the form of remimisolam. It was invented by the parent company Japan, and it is available outside India everywhere. Every part of the continent it is available, but India is a little bit. It will come after 5 to 10 years. It has a property of benzodiazepine with opioid. It is available very. See, the bulb is available $25 in USA, so almost 1,800 rupees in India. So most ideal sedative drug. It is also like propofol switch on and switch off drug. Once this will drug come in the anesthesia practice, then you do not have to instead of propofol you will use these drugs, and this is very for the short procedures. Adjuvant TIVA drug midazolam. Nowadays this is drugs of ICU interest, and the dose is 0.05 milligram per gram. Total dose should not be more than 10 milligram. Midazolam infographics. Magnesium sulfate, one of the most versatile drug, and it is called as a very good friend of the anesthesiologist. So analgesic, I will give you that how it comes, how it will be helpful to anesthesiology. Antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizure, anti-shivering, anesthetic adjuvant, antacid. But in journal, it has given a 32 clinical effects of the MGSO4 during anesthesia. These are the listed. So it is called as a versatile drug for anesthetics, and the same name, versatile drug, reinvented by the anesthesiologist, is a magnesium sulfate. There is a very good article in the literature. You go and read it. So I called it a old wine in a new bottle. We know MGSO4 since last 30 years, but nowadays it is used by the so many anesthesiologists, and I call it is a intravenous oxygen for the anesthesiologist. Dexamethasone. Nowadays, these drugs is also used by all the anesthesiologists in a 4 to 8 milligram, and it is an anti-inflammatory, prevents and treats post-operative nausea and vomiting. It is compatible with the ondansetron. It's a provides sense of well-being. So I recommend to use this agent also in your TIVA practice. And I call it a universal weapon for the anesthesiologist because it is antiemetic, anti-nauseatic, anti-inflammatory, analgesic, anti-shivering, increase the quality of the recovery. Third drug is lidocaine, xylocaine, which is IV xylocaine, analgesic, anti-hyperalgesic, anti-inflammatory, reduce opioid analgesics, anti-arrhythmic, improvement in patient's outcome, and decrease the aerosol and droplet during extubation, which we have found in the corona time. So my request is, whenever you do any TIVA practice, use lidocaine, magnesium sulfate, and dexamethasone whenever you get the chance. So it is a magic drug. It will regularize all the organs in the body once you give 1 to 1.5 milligram per kilogram body weight in the dose to any patients. Now, some of the adjuvant is as NSAIDs are paracetamol and diclofenac sodium. We use sometimes in major surgery or minor surgery like paracetamol. It is a pediatric TIVA. In pediatric TIVA, paracetamol is very, very important. But remember the thumb of rule. Always give both the drugs before surgical incision to inhibit prostaglandin receptors. Because once the incision is given, then if you give this paracetamol and diclofenac sodium, then there is no effect. IV paracetamol, diclofenac sodium, esmolol. Nowadays, esmolol is coming as a very, very popular drug as a beta blocker in anesthesia. It is called as an emergency friend of anesthesia. Believe me, I am using these drugs each and every patient when I am intubating, like laparoscopy, urology, or neurosurgery, or in my any sort of major surgeries, because it gives very good, very short acting. It gives central analgesia, and it has got an opioid sparing effect. So use these drugs. It is available freely. TIVA drug combination. What to understand before mixing any drugs for anesthesia? Nowadays, TCI pumps are available. The drugs are given independently. So, but when you don't have this lectures I have prepared so many 10 years before, and I am updating this lecture. So, I am mixing the drug. I am a mixture man. What to understand before mixing any drug for anesthesia? Anesthesia triangle. We have learned about the anesthesia triangle of the hypnosis, analgesia, and relaxation. These three action will complete about the anesthesia circle. And any drugs which enters in this prism, they have to go by the pharmaceutical, pharmacokinetics, pharmacodynamics, and thermodynamics reaction. So rule is not mix more than 3 drugs. And there is a very good article given in Columbian Journal of Anesthesiology about the which drugs will be mixed with the which drugs. I have created one TIVA kingdom. Those who want to practice as a TIVA, then you are the queen or king. And your first prince is propofol. Your supreme commanders are ketamine and dex. Your other reserve soldier, your commanders are fentanyl, remifentanil, and others are soldiers. So when king will decide their military in battle of the TIVA, whom to send alone or in combination. Suppose if you have a short cases, then you can use only propofol and some sort of any narcotics. Or sometimes when you are having a time, then you can send your supreme commander or commanders. But when you have a short battle like pediatric TIVA, then in absence or presence of prince, 2 supreme commander go to win some battles like ketamine and dex combination. Now about TIVA maintenance in war during the long time of the prince with the 1 or 2 supreme commander or other commanders are the best military of the king. So prince is the most common variants and goes in every battle of the TIVA and TCI. So propofol, you remember, without propofol, TIVA and TCI practice is nothing. Now these are the mixer KPD, ketofol, ketodex or dexket, and PDF, MDF, ketomed people are using in India. Ketofol, see the rule for any mixture of any drugs, ketamine, midazolam, dexmedetomidine, propofol, whatever it may be. Thumb rule is 1. You just remember 1. Either 1 milligram per kilogram ketamine or 1 milligram per kilogram propofol or 1 microgram per kilogram dexmedetomidine and this midazolam 0.1 milligram per kilogram, right? Now I have also developed on KPD TIVA. This I started just 7 years back with the ketamine, means in corona period. Mixture of 1 gem dose for TIVA, ketamine, propofol and dex. So 1 milligram, 1 milligram, 1 microgram. Combination of all these drugs permits low dose of each individual agent for TIVA and reducing their adverse hemodynamic and respiratory effects. Used as a bolus, maintenance in short cases. I have done with these combinations more than 10,000 cases. The advantage is low dose and each agent is compared to full dose. I'm talking before the era of TCI. TCI just came and popularized in last 3 years. Before that, I was using this combination as a maintenance dose as well as in the induction. Why it was given excellent analgesia and anesthesia? Dose of individual decrease, stable hemodynamics, decrease the airway complication and rapid. Each drugs there mimic each other's effect. Propofol fentanyl, it is now outdated. Propofol remifentanil is now coming as a very popular combination with the TCI. Methods to give either with the single drug or with a combination of drugs, single syringe technique or mixture of the drugs with only one drug, continuous IV infusion through drips with syringe infusion pump, and total target control anesthesia, target control infusion. This is a new technique came in the TIVA and now it is a ruling all over the world, and without this now TIVA practice is nothing. And automated drug delivery system, closed loop anesthesia, CLADS. Single syringe TIVA, everybody has given single syringe TIVA with the propofol only or with propofol ketamine combination or some other combination like Dexket in pediatric patients. So you know that how to give it. Manual control, manual dosing of anesthesia during TIVA with fixed infusion rate with syringe or with IV trips. Propofol manual infusion when this pharmacodynamics, pharmacokinetics model were not introduced, then it was given in the Bristol regimen. Target was 3 microgram and loading, how it was given? Loading dose 1 milligram per kilogram. Before that, we have to give some narcotics. 10 milligram per kilogram per hour for 10 minutes, 8 milligram per kilogram for hour for next 10 minutes, and 6 milligram per kilogram per hour thereafter. And you can go on for 6 hours, 5 hours, whatever the surgery time is. 6 milligram per kilogram is a load maintenance dose. Now people are telling, can we dilute propofol in TIVA? Yes, we can dilute. It is FDA approved, but the dilution should not be 1 gem 4. 1 part of the propofol with the 4 part of the dilution, and it can be mixed with any sort of any pints or something like that. And how to prepare? Take 100 ml of 0.9% of normal saline, remove 20 ml of solution from this infusion, add 20 ml 1% propofol in 80 ml normal saline infusion. So this infusion contains 2 milligram per ml propofol and 6 milligram per kilogram per hour dose for maintenance it will complete within 30 minutes. So the concentration will maintain the propofol in the body, right? Total intravenous anesthesia sets are available like this. Target control infusion will be taken care by the Dr. Kalpana, but it's a target control infusion is an infusion control to achieve preset drug concentration in the plasma, the effect side. See, it is like a cruise control of the car. Once you put the speed and everything set, then the things were going on by the chemistry of the patients and parameters of the patient, right? Key components of everything will be taken. These are the how TCI will work. All these will be taken care by Kalpana. TCI-TIVA sets are available. TCI-TIVA infusion model, specific drug model and general purpose. Suppose for propofol PKPD model is different, but in one pump you can find all the models even. Third generation pumps are available now. First generation, second generation, the third generation. So these are the pumps, different pumps are available in the TCI pump I am talking. Arcomed, BDLR is HP Med Captain, B Brown. Now Mintre pumps are also available. Single syringe, double syringe, 3 syringe TIVA. He is the father of this TIVA TCI. Deprefuser he was invented in 1996. John Bayard Glenn, he was from UK. So TCI has a more predictable onset, more predictable offset, and everybody has to use now TCI and everybody has to train in this technique. Now patient control sedation by TCI also came in market. So these are the different TCI-TIVA pumps are available with the models like Mars model, first generation, Snyder for second generation, Alivel for propofol and remifentanil is third generation. And these are the drugs for different models. And all TIVA drugs software in one TCI model. Suppose in one Arcomed pumps are available with all types of models in one pump. Now I have developed tushar Chokshi infusion like TCI. TCI also tushar Chokshi infusion, 3 styles. KPD infusion, dexmedetomidine infusion, or propofol infusion. And these are the rate how I am using without TCI machine. This I was using just before invent of the TCI in India. Closed loop system, it's a clad input and output. Input is a drug delivery. Suppose this is the output. This is the output. Output is a drug delivery like propofol opiates, and input and output is a all anesthesia depth monitor. So according to patient's vital signs, the computer will decide which drugs to be given in the system. So this is a vicious cycle. So it is a closed loop circuit. These are the anesthesia machines, and with closed loop anesthesia systems are available in market. And one of the Dr. G.D. Puri has invented this system in India and all over the world. TIVA can be given in different sets of the patient like pediatric, geriatric, obese, and ASA3. TIVA in pediatric patients, I have given that I have told you that Dexcat is a major role in the TIVA practice in pediatric, and you can maintain with the TCI pumps are also Kataria and Pedfuser for propofol is available for the pediatric patients. Pediatric patient we can give in any pediatric patient for any surgery this TIVA. Even TIVA can be given in geriatric patient. The rule is go low, go slow, and always follow. Start with the low dose, give very slowly, and always follow this situation. So you will conquer this TIVA practice. TIVA can be given in obese patients also, but the rule is always give suxamethanam whenever you put your any airway gadgets. TIVA even can be given in ASA3 patient like geriatric patients or very slow dose, but whether the patient is elderly or young or whether the patient is obese or non-obese. But you can give very slowly with the titrated dose with the tailor-made anesthesia. So surgical procedure done under TIVA is from OT to outside OT, from pediatric to geriatric, or from any surgical to medical specialty, which I quoted in the first slides. All procedure, if somebody says that I can, even Dr. Kalpana has completed more than 2,000 patients in cardiac surgery with supraglottic airway in TIVA only. She will tell you that afterwards. One of the checklist is all anesthesia drugs, airway equipment. See, this is the routine for the all TIVA or inhalation anesthesia practice. All drugs, airway equipments, oxygen, multi-para monitors are must before giving TIVA or TCI. Ensure no leakage from cannula. Syringe should be labeled. This is my very important message to everyone. Syringe should be labeled. At this age, after 35 years also, I am labeling my syringe myself. So beware of that. Infusion line should be checked every 15 minutes. should have a lever lock. If BC is used, then check placement before and after surgical draping. At the end of the case, ensure all tubing IV cannula which had TIVA drugs by any method are flushed to prevent inadvertent blowholes in the ward. I had an example when we had given in tonsil just 15 years before for repeated scoling in tonsil anesthesia, and last dose was given, and after that patient was shifted to in the ward, and sister has given post-operatively antibiotic, and some of the 0.1 ml even this scoline was there in the tube line, and patient became unconscious. So beware of that type of practice. This is praise to start TIVA. This is a beautiful infographic given by the this in SIVA people, that is propofol remifentanil. How to do this practice? PRESS, propofol remifentanil, electricity, setup and setting, and start TIVA. So TIVA monitoring, see, no doubt, anesthesia depth monitor is compulsory when you are practicing it as a TIVA or TCI. But I'm an old generation anesthetist and started from ether. I started my ether practice to the latest gadgets. So anesthesiology is the most vital parameters in this practice. And we have to see that how the TIVA can be given. Loss of response, loss of hemodynamic response to limb movement, absence of tachycardia, and machines also, multi-para monitoring, bispectral index, evoke potential, process EEG machine like that. So minimum requirement of the TIVA start or TCI is dedicated TIVA or TCI pump, dedicated TIVA lines, non-return valves, anesthesia depth monitor. So my bottom line, what is TIVA and TCI? Why became popular, practical, and possible? First, the advanced knowledge of the PK/PD model of the drugs like propofol, ketamine, dexmedetomidine. And second, new concept in the PK/PD model came in the, just LEVL model came in the market. Third generation model came in the market just 2 years back. And it has conquered the world in all over the PCI practice. Now patients are not even, patients are, after even 6 hours of surgery, patients are waking with that, sir, what happened? I am very comfortable. ERAS is very good. So these type of the things are happening in TCI. TCI will rule in 2030. So propofol with remifentanil is the ruling in the world. Some of the TIVA apps for the all the postgraduate, iTIVA plus anesthesia, IV calculator infusion, anesthesia infusion calculator, and TIVA manager. Now, one of the books, textbooks, which I am giving to Dr. Divya Gupta and Dr. Sudhi, that total intravenous anesthesia and target control by the Absolam. This is the first textbooks available in the world by for TCI. First edition is out of the way, but we have a free copy. So TIVA and TCI, in fact, patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly. What else you require? TCI-TIVA will be a norm in future. And you won't believe that I never touch any inhalation agent in my life, never any benzodiazepine, never any this narcotics. Now I am only and only practicing TIVA and TCI since last 10 years. Future, everything like vaporizer. My dream is that like vaporizer, syringe pumps and TCI system will be integrated in the anesthesia workstation. TCI will rule in anesthesia technique by 2030. And this dexmedetomidine and other models are available now. Auto TIVA by artificial intelligence and metaverse with help of the TCI TIVA. All in one TCI TIVA. We have a TCI and CLADS together. Even in between that, you want to play some game in TCI pump, then you can have this type of the situation. And this, see, nowadays we are working this type of the theater with this type of wires, gadgets, machines, and everything. I don't like this type of. So, what is my dream? I have created my dream after 30 years of 25. It will be true things in my life when I, even if I will die after 20 years, then also this will be a reality. Future anesthesia workstation. It will be having a one button only. When you want to put your patient in the sleep mode, means anesthesia mode, then just put on. And you want to put your patients on awake mode, then you push just on the awake mode. And in between, if you want to have a coffee, then vending machine is also there. So switch on, switch off anesthesia machine. Newer drug came in the market, Remimazolam, Sugamdex, Ciprofol by China. So take home message is total intravenous anesthesia is a viable and safe alternative to the inhalation anesthesia with lots of advantage over the later. See, I am not against at all of the inhalation anesthesia. I'm still using some parts, some anesthesia drugs are not available, then once in 1,000 case, I'm using inhalation agent. I never dropped my practice, but it is an alternative to inhalation agent. TCI pumps and advanced monitor make administration of TIVA easy and precise. Manual control infusion using regular syringe pump can be used to deliver pre-calculated dose if you don't have any infusion pump or any TCI. And newer intravenous hypnotic analgesic agent favorable to pharmacokinetics property have made TIVA more popular in wide area of varying clinical scenario and anesthetic demand. Nowadays, even neonatal age patient also can be given in TIVA and TCI. So patient wants more than anesthesia. So start today onwards. My request is in your practice, at least 20-30 practice, you start with the TIVA or TCI. And what is your opinion of using TIVA and TC in your practice? I want not down steps. I want a up stair. Yes, I won't use TIVA. I can't use TIVA. I won't use TIVA. How do I use TIVA? I will try to use TIVA. But my message is very clear. Yes, I have used TIVA. That I want to hear from everyone. So we have our society, Association of the TIVA TCI Anesthesiologists, and it is available on the Facebook, available on the YouTube, available on the web, and you can become a member. We have this year also we are going to have a national conference in Bangalore just after our national conference. And different TIVA societies in the world, EuroSIVA, World SIVA, and we have a world conference from this SIVA. So in July, we are organizing by Dr. G.D. Puri to World Conference of the Intravenous Anesthesia. And I always love my TIVA and TCI. With